The BC chapter of the Canadian Association of Critical Care Nurses welcomes you to our spring roundtable that was held in April of 2024. These were three of the presentations that were shared. The final presentation was led by Angela Wignall, and she discussed policy competencies for nursing.
Thank you so much, Sybil, and good morning still for me, everyone. I really appreciate you having me here today, and I will just get started with sharing my screen, so give me a quick moment to do so. Wonderful. Thank you both. Thank you so much. So, as Sybil indicated, my name is Angela. I am a registered nurse, and I serve as the Director of Professional Practice and Health Policy with the Nurses and Nurse Practitioners of British Columbia. BC's Unified Professional Nursing Association, and I'm going to share a little bit more about what that association means. I've been asked to focus on a bit of a policy-specific conversation. So that's where I'm going to go today. I'm hoping I'll share for about 20 minutes, and then I'd really love to hear about some of the questions and opportunities that are coming up in your work around policy-specific nursing work. I'll let you know that I'm joining today from the unceded homelands of the Lekwungen-speaking peoples, the Songhees and Esquimalt First Nations, which is today known as Victoria, British Columbia, and also acknowledging the nurses who we support who work across what is today known as BC, which includes the homelands of 203 First Nations, chartered Métis communities, and sheltering Inuit as well. So I think it's always important to share a little bit about who I am so you know the ways in which I'm coming to the table. I often joke that I'm a policy scientist who became a nurse. I have a previous career in policy development and a master's in policy and practice. My PhD research focuses on nurse-led policy coalitions. So when I say I'm a policy geek, I really mean it to my core. I'm also a clinician with a practice background in perinatal and public health. I lead in nurse-led innovation in a fantastic innovation lab that I founded at Island Health and continue to be connected to. And of course, I am also a mom and a partner to a fantastic licensed practical nurse. And so those are some of the aspects of who I am in this conversation today. And I'm joining you from a very specific working location as well. We are a professional association, and sometimes there is confusion or it can be hard to understand the sort of three-legged stool of supports and enablers for nurses in BC, and of course in other jurisdictions as well in Canada. But we hold a unique space. So the Regulatory College in BC, known as BCCNM, their job is to protect the public. And so they hold our licensure, they hold standards, limits, and conditions on our practice, and they set out regulation in relationship to the legislation that articulates what nursing is here. And then, of course, we have our extraordinary union partners and labor relations organizations who really focus on that employee-employer relationship. And they do incredible work ensuring nurses are safe at work, advocating for nurses, and of course, collective agreement bargaining, which is critically important for many nurses who are unionized. And we sit in that third space. And we have a great deal of flexibility and freedom because our job is to act on behalf of the profession of nursing and advance that profession and to influence health and social policy in the ways that only nursing can. So as the professional association, we have a little bit of a different role. And we often talk about that in terms of the 3 Ps, protect, pay, and promote. So of course, our regulatory body protects the public. Our unions and other agencies support that employer-employer relationship, which can be characterized as pay, but it's so much more as well. And then promote, and that's really the role of NMPBC. Some folks like an example, again, because it can be a little confusing. So we often use this example to talk about the association. So when we think about a moment when there's a complaint about a nurse's practice, the association's job is to really situate that complaint within the broader system, advocate for changes that reduce risk to nurses, ensure quality practice environments, and advocate for supports for nurses. Regulators investigate and resolve those complaints in relation to public protection. And of course, fantastic union stewards often walk alongside nurses going through that complaints process. So here at NMPBC, we work towards a vision of transforming healthcare through nursing expertise, and we do that through all domains of nursing. So our members are researchers, educators, clinicians, vice presidents, board chairs, anyone and everyone who self-identifies as a nurse gets to be part of the work that we do. And we do our work in a bunch of different ways, but the area that I'm going to focus on today is professional practice and health policy. And that is the portfolio that I lead. But just so you're aware, NMPBC also has membership services. We have primary care programs like the NP provincial initiatives and programs. Of course, we focus on anti-racism and diversity, equity, and inclusion with a specific focus on Indigenous specific racism. And so those are some of the aspects that I'm not here to talk about today, but if you go to our website, you can find out much more about the full breadth of what the association does. So I think it's important to situate professional practice in the ways in which we talk about professional practice, because the practice of nurses informs the policy work of nursing. And so we really focus on ensuring that nursing has what it needs to provide safe, competent, and ethical care. We advocate for nursing presence at every table where nursing is discussed and where knowledge is centered. We focus on maintaining and advancing self-regulation and practice autonomy, and of course, advocating for structural change that enables nurses to live to the full scope of their skill and expertise. Professional self-regulation is a cornerstone of talking about policy in nursing, and I also have found that it is one of the most poorly understood concepts in nursing, particularly for so many of us who have worked at the bedside. The self-regulation concept is a bit amorphous. So I thought I'd spend a couple of minutes just talking about what self-regulation means as autonomous professionals. So self-regulation is a regulatory model that enables governments, so folks who have been elected by our citizens, to exercise some degree of control over a profession. It's not quite the same as full control over a profession. And the exchange between the government and the professional group is that the professional group commits to regulating the activities of its members by developing enforcing rules that protect the public. And so you can see the obvious next step, which is a regulatory body like our provincial college. And their job is to enact that relationship between the government and the profession. Licensure or self-regulation also creates a monopoly over the profession, basically a boundary around who says I'm a nurse and who cannot say I'm a nurse. And that provides us with a high degree of autonomy and authority. And most importantly, self-regulation respects that nursing has a unique body of knowledge that is possessed by the members of its profession. That's not the same as any other professional or disciplinary body of knowledge. Professional autonomy comes from that professional practice self-regulation. And it is really a concept around the reality that nursing is independent. We are independent practitioners of nursing. We engage in clinical reasoning grounded in that disciplinary knowledge of nursing. Every designation of nurses does this: LPNs, RNs, RPNs, NPs. And we apply that disciplinary knowledge and expertise to clinical decision-making, but also systems-level decision-making. And that results in the exercise of judgment that is enacted in the care and interest of a patient. And we define patient really broadly. It can be a person who you're with at the bedside, a family, a community. And for someone like me, my patient is the healthcare system. So I apply the same principles of nursing to my caring work as I would to a patient in front of me. And really importantly, professional autonomy is twofold. It articulates that nurses have authority to make judgments about patient care from a nursing perspective, and we have control over nursing practice, and that includes nursing control over organizational structures, policies, operations, and practices. And for all of you who are nurses on the call, you know that there are many instances where nurses are not provided with that control over nursing practice or that authority to articulate what nursing means within our healthcare systems. And that's something that we really strongly strive to advance. We, of course, work within the controls on practice framework. I'm not going to go into too much detail there, but that's always ever present as part of our regulatory structure in British Columbia. So moving away from professional practice and into this understanding of policy. Professional practice and self-regulation is an articulation of a relationship with government, and that is specific to nurses. And nurses engage in a multitude of practices, and in many locations, in fact, I would argue all locations, nurses engage in policy practices. And when I talk about policy, I really mean something quite specific. And this comes from my policy science background. I mean health policy as a branch of social policy under the broader umbrella of public policy. So public policy is essentially a tool for public governance. And sometimes folks get a little uncomfortable with that language because it sounds like we're trying to exercise autocratic control, but it really just means that as a public, we have decided we're going to move in certain directions as a society, and we create public policy to help us get there. Within public policy, there is a branch called social policy, and these social policies are really aimed at governance of the social conditions of a population. And within social policy, there's this third branch or third layer, which is health policy. And these are specifically policies related to the health of the population as a branch of social policy. You might also hear language called healthy public policy. And I have to be completely honest, I do not use that language, and I don't use it very intentionally. Healthy public policy is simply a way of describing public policy and moralizing it. So we're saying it's healthy, but we don't really define what healthy means. Sometimes it's a stand-in for evidence-informed public policy where health is used as a descriptor. But for me, that's non-specific. And so I don't use the language of healthy public policy because for me, it doesn't really articulate what policy means. When I talk to people about policy, I often hear very similar things, which is when I ask what policy is, people respond with it's a piece of paper stored in an accessible location. So 9 times out of 10, someone will bring a binder and say, this is policy, and they'll put that policy binder down. Sometimes policy is a replacement for performance management. So someone is doing something we don't like, and so we write a policy to make them do something else. Sometimes policy is articulated as legal protection against prosecution. So the absence of having a policy can help an organization not be liable for the activity of self-regulating autonomous professionals, because if you don't have a policy, you can't be responsible for actions. Sometimes people experience policy as coercion. So leadership is asking me to do something. I don't want to do it, but there's a policy, so I have to. And my favorite one, which is, Angela, please go away. I don't want to talk about policy. You're interrupting the work that I do every day. And what I do every day is just fine. And so these are all real. None of them are wrong. But I will share with you how I think about policy because it isn't quite in these ways. For me, what policy really is deeply aspirational. And it's part of why I love policy, because it is a hopeful activity. When we engage with policy work, we are aspiring to an ideal world where if the conditions were perfect and we have what we need, we would be able to operate, move, or create a society, institution, or group in a way that's really ideal. It's also a really important record of evidence underpinning practices undertaken by the public and for the public. So as a nurse who's invested in evidence-informed practice, it's really important to me that our policies have a record of that evidence within them. It's also, because it's social policy and its goal is to govern certain groups and behaviors, it's a tool for communicating those behaviors to individuals and to groups. And I love well-written policy because it's not opaque, it's not legalese, it's really accessible. Sometimes policy is doing something, and sometimes it's doing nothing. And really importantly, policy isn't always written down. It's sometimes commonly held practices and beliefs. And as a nurse, I think we all know, if you're a clinician like me, you know that moment when the policy says one thing, but Stella, the incredible nurse who's been there for 42 years, tells you something else in the med room. 9 times out of 10, you're going to try what Stella's told you first before you go to that policy. So it can be circulating beliefs and practices. And in that way, it's both formal and informal. And something that folks find sometimes distressing about policy is that it moves quite slowly. We often talk about ruthless incrementalism. It takes a lot of work to pivot a large group of people into different kinds of beliefs, behaviors, and ideas. And so policy can sometimes feel really slow. And really importantly in nursing, policy is what we hope people do behind closed doors. We're communicating a desired behavior, vision, articulation of a social reality, and we are handing it to someone and saying, please consider this when you're all alone and no one is watching. In Canada, of course, we have a very specific governance framework for health policy. We have our federal level, which is legislation, regulation, and really critically for us, funding. We have those federal transfer payments that fund our healthcare system at about 50% right now in BC. We also, of course, have the provincial level and in some places territories. So the provincial governments and territorial governments are responsible for the implementation of healthcare. And so from province to province and territory to territory, the healthcare system looks really different because of that autonomy in our federalist model. And then here in British Columbia, within the province, we have regional health authorities, which aren't the only entity delivering healthcare, but certainly the largest. And then where many nurses sit, we're in this blue box underneath all of these layers, which are our programs and services. So myself as a perinatal nurse, I might be in perinatal services, but what is bearing down on my practice or informing my practice are the regional health authority policies, our provincial legislation, regulation, and oversight, and of course, national governance and thought leadership around certain nursing issues. We do this work in a larger policy landscape as well, or a context. And in policy science, we talk a lot about those contextual layers. So we always are working in a wider context of cultural, political, economic, and public issues. So when we talk about, for example, cultural safety and anti-racism, we're talking about that wider context that has structural repercussions. And when we talk about structural context, we're talking about resources, partners, responsibilities, and positioning of activities within certain parts of a system. And then, of course, there's our local or specific context, which are beliefs, our social groups, our ideas, our units, and the ways in which we decide to take action. This is a map of the BC landscape for health policy that was actually gifted to me by a dear colleague. I use it with acknowledgement of him, Torben. And I share this slide often because I think it's a really good example of the complexity of the policy landscape in British Columbia. Often when I'm talking to nurses or nursing students, they can situate themselves within one of these boxes. So they're in, for example, for myself, when I worked at Island Health, I'd be in that VHA box. But there are all of these other players who are intersecting and interacting with the work that we do at any given moment. And when we think about policy change for patients and populations, it's important to have a read or a bit of an understanding about the attributes of this policy landscape and where we might go. So for example, at NMPBC, I work often with the doctors of BC, with the College of Pharmacists, with members of government, with our health authority partners, Health Quality BC, and we're moving pieces of work across this landscape. It's complex, it's difficult, but it's deeply meaningful. I'm going to just really quickly touch on a few key concepts. I know I'm keeping it to a tight half hour. But I want to share a few things about ways of thinking about policy, because sometimes it can be hard to find policy when you're looking for it or understand a policy when you see it. So I tend to use these three sort of categories or clarity of focus for understanding what policy is. So policies can be issues. They can be any discussion, debate, or conflict or desired change. When you're talking about implementing new IV pumps on your unit, you're talking about policy. You're talking about a policy issue. A policy problem ups the stakes a bit. It suggests that, okay, we have an issue, and then we're going to agree to take action on that issue, problem, idea, or desired change. And we know who is going to take that action and where they're going to take it. So when I say we're working a policy problem or we're doing policy nursing work, we're really in not that place of issue debate. We've moved beyond that, and we're into working a policy problem. And then for me, as a policy leader, a lot of the work that I do is advocating for policy change. And so in that work, we focus on creating policy agendas. So that is a group of policy problems. So we've identified the issue and we know who we'd like to take action. We share our policy priorities with other people, and we consider the contexts within which change is possible. And we work with those partners, with those members of government, and different methods and approaches to getting over barriers to change. So issues, problems, and agendas are really quite different, and they can be helpful when we're thinking about what does policy look like in the course of our work. And then there's sort of 3 types of action that we can take when we've decided to take action on a policy problem. We can provide advisory. So nurses are often asked to advise on other people's policy. So we provide evidence, expertise, and opinion. Sometimes we do that through expertise, think tanks. Sometimes we're consulted on a unit, or we're pulled into a committee to work on a clinical policy in the course of clinical governance. And sometimes we feel passionately and we take the next step, and that is advocacy. And our goal in advocacy is really to influence decision makers and sometimes to influence the public directly. And so that can be, as a public health nurse, public education around health issues is advocacy. Campaigns, generating knowledge as a nurse researcher, we are engaging in policy advocacy. And then for some, they really identify with activism. And activism is when we're really explicitly campaigning for change. So we're not advising somebody else's version of change. We're not advocating in a collective, but we're driving forward in a very specific policy direction. And that is a very useful tool for nurses to have in our policy bucket. And that includes demonstrations, boycotts, letters to the editors, social media campaigns, and in some instances, and in some countries today, while we're talking together, it includes civil disobedience of nurses. And so our role in health policy with NMPBC, what it looks like for us is we really advance the nursing voice in health and social policy. We really focus on advocacy and advisory. We're not really in the activism space, although we cheer on those who are. And our work is to build policy coalitions so we can advance policy problems and take action and see action from a nursing perspective. And I have to share this beautiful photo of the Indigenous nursing group who last week sat with myself and others in the House at the legislature in BC and witnessed the first reading of the proclamation of Indigenous Nurses Day on April 10th and had some time with Minister Dix thereafter. So moments like that really shine when we see the results of our work. Sometimes it looks really fancy. It looks like those posed photos with political leaders or chief nursing officers at the WHO or a fantastic chief nursing officer of Canada, Lee Chapman. Sometimes it looks like writing. So it's our position statements, our issue briefs, it's blogging, it's being on podcasts, identifying policy priorities, and writing position papers and academic articles. And sometimes I always like to include this. It looks like being very confused, being stuck on an airplane and doing a whole ton of work with a bunch of working groups and reading 72 pages on a Saturday morning. So the work of a policy nurse can look really different, and not all of it is, fancy, fancy schmancy. So I'll end with some recent examples of work, again, to try and contextualize this understanding of nursing policy work. So regionally, we work to support policy offices and nursing leaders in health authorities, and we provide coaching, mentoring, and support for individual nurses who are taking policy actions. We also, of course, participate in many policy tables with the Ministry of Health, the Ministry of Mental Health and Addictions, and so on. And we provide policy advisory for governments, non-governmental organizations, and private enterprise as well. So all of the folks within that policy landscape, we endeavor to be in good relationship and to advise them as they need, and really critically. And so, nationally, we've just had a great moment with the release of the Nursing Retention Toolkit and participating in the expert advisory group there to really advance examples for nursing retention. And then we do some work internationally with the International Council of Nurses as well. And so, I was asked at the very end here to touch on some nursing policy issues of interest, and this is how I'll conclude my time. I know that nurse-patient ratios is a hot button issue for us in British Columbia, and not only for us here, but provinces and territories across the country are watching BC closely to see how this unfolds. And there's, sort of two things that I'd like to share around the nurse-patient ratios, acknowledging, of course, that this is not NMPBC work. This is the incredible work of the BC Nurses Union. It's really important to understand that nurse-patient ratios is not legislated. So when we talk about legislation in relation to minimum nurse-patient ratios, that's not what we're working with. We're working with a policy direction. So the government of British Columbia decided in collaboration with BCNU to advance mandated nurse-patient ratios. So that policy direction is unfolding, and it's can be a very good thing that it's not legislation, because legislation takes a long time to change. So a policy direction is accessible, it can be enacted, and it can be enacted more quickly. What I think is really important to remember is it is a long road. So this is an incremental implementation. Many folks want to see those ratios right now because nurses are suffering and they are showing up to units to work with ratios as high as I've heard personally from nurses who are working 1 to 26 patients in an acute care setting. This is an incremental implementation. BCNU has announced some of the first key areas with the established ratio direction. More is coming in June around those specific ratios for different areas of care. And the implementation of this is going to take years. And again, when we think about policy work, we think of ruthless incrementalism. So we're not going to give up. We're walking in this policy direction, but it will take time. And of course, one of the things that I get asked often about the nurse-patient ratios is, well, ratios are great, but where are these nurses going to come from? And the good news is we have jurisdictions in other parts of the world who have demonstrated that when ratios are implemented, nurses come. They return back to the public system. So we're taking our hope from those jurisdictions. I also know that decriminalization is top of mind right now with lots of the activity in the legislature in question period and in the media as well. I'd be happy to talk about that a little bit. And of course, we're all working within health human resource scarcity. And really our focus at NMPBC is ensuring nurses have quality practice environments. And that looks like safety. It looks like psychological safety. It looks like safe patient staffing. It looks like opportunities for professional development and continuous learning. And what we know from decades of research is that nurses leave publicly funded healthcare not always because of the money, in fact, very rarely because of money. They leave because they are suffering at work and they cannot provide the kind of nursing care that they are trained and want to provide. So I'll leave those policy issues of interest for a dialogue, and I will end my time there. If you want to get in touch with me, all you have to do is Google NMPBC. You'll find me. I'm also the only Wignall around a lot of the time, so you can find me online quite easily if you'd like to connect. And I really appreciate the opportunity to chat with you about policy. As you can hear, it's my passion. It's the thing that I love doing the most, and I hope that something in this conversation is useful for you as you think about policy work in your own practices.
Hey, thanks so much, Angela. That was fantastic. I learned a ton. One thing that I think I'll take away from that a lot, but one thing in particular is when you said that policy is what we hope people do behind closed doors. And I think that really sums it up really nicely for sure. And I also appreciate the clarity around the minimum nurse-patient ratios, but you're right, it is very top of mind for a lot of people. And so thanks for providing a bit of clarity around what we can expect for that process. And it certainly helps me understand from the level of Critical Care BC how I can help influence some of that policy with the folks that we're working with. And I anticipate I'll be reaching out to you for a little bit more guidance around that as we go forward for sure.
That is what we are here for.
Perfect. That's great. Are there any questions online for Angela or comments? Thank you so much for coming to present this for us. Alana, I see your hand. Go ahead.
Thanks so much, Angela. This is an incredible sort of overview of really how nursing situates within policy and vice versa. I'm curious, If nurses, whether at the bedside or in positions of, say, leadership, have a desire or to influence policy, what would be the best advice that you could give?
Thanks. That's a great question. I think there's lots of ways to influence policy, and I always come back to something that I observed very early on in becoming a nurse from a policy science perspective. So, as I said, I came from political and policy science, and then I came into nursing, and that's a whole other story. I can tell you about that sometime. But what I noticed immediately was the common ground of relational practice. So, in policy work, there is a very rich understanding that policy and political action and success in political or policy advocacy is 100% contingent on the relationships you have. It's relational work. And that's not to say it is intentionally manipulative, you're not leveraging relationships in an unkind way, but you can't advance change without groups of people. It's collective social work. And so when I became a nurse, I was very pleasantly surprised to understand that nursing is grounded in relational practice as well. We articulate it very differently. We don't write about it and talk about it in the way that political scientists do, but it's the same work. And so I think one of the most important things that we have going for us already is our capacity to engage relationally. So the more relationships you can build, meaningfully, authentically with people who are in very diverse settings. I often, when I talk to political science students, I try and remind them that, the best thing you can do is spend time with people you really disagree with, because you can't understand why they're coming to the problems that you're both sharing from the perspective they're coming to if you don't spend time talking to them. So going into those relationships that are a little tense, that are a little difficult, being brave in regards to hierarchy. There is no reason why a nurse with the expertise we have should not be reaching out to any relationship that will help them advance a change. So leveraging your relational practice skills, I think, is one of the most powerful things we can do as nurses to influence change. It's also really helpful that nurses are the most trusted profession, right? And so when we step forward and we say, I'm a nurse, I want to talk to you about X issue, it has power behind it, particularly with public officials. When we're talking within healthcare systems, we actually see the inverse. So when you say I'm a nurse first, it can actually be punitive. And so there are hundreds of examples of nurses who are attempting to advocate for change, but the response they receive from people is, I'm just a nurse, or you're just a nurse, or this is work for medicine, this is work for leadership. And I would say that the next best thing after, if that is the response that you're getting, is to leverage the knowledge of nursing and increase your numbers. So if you're alone in those conversations, remember that there are 66,000 nurses in the province, 440,000 across the country. We are the largest group of care providers on the planet. And when we are united, we can change everything. And then the last thing I would say is just don't let them get you down. Have amazing self-care practices, have a community, have that person you can call, because this is tiring, difficult work. It is lifelong work. I am a feminist. One of my favorite pieces from feminist theory is that women engage, and I use women because I self-identify as a woman. Women engage in multi-generational work. We are never doing work for one generation. And I believe that very fervently about policy work. It is multi-generational work. If I can advance something incrementally in my lifetime a small bit, I will have done the job that is mine to do. And likely my next job is making sure there's someone coming behind me who can do that next incremental step. And again, nurses are really awesome at mentorship. So we've got lots going for us.
Thank you. That was an incredible answer.
Great question.
Yeah, thanks very much for that, Angela, for sure. And one of the comments in the chat was about your the phrase collective social work. I think many of us might coin that term from you after this presentation, for sure. Yeah, thanks very much for your presentation. I know I've learned a ton from you.
Thank you so much for having me. And I do have to step away now, but I so appreciate the opportunity to join you today. I hope the rest of your day is wonderful and be safe. Take good care.
Thanks, Angela. You too.
Bye.
Thanks for watching, everyone, and thank you for joining us on the BC chapter of the CACCN YouTube channel. We have a lot of great content. I would suggest subscribe and hit the notification button so you can know when the next thing is out. And if you ever want to come to our next event, we're on Facebook and on Instagram. Our links are listed below. And while I'm on the topic, if you're a critical care nurse anywhere in Canada, why don't you join CACCN? We have a ton of resources to help you be the best critical care nurse you can be. Go to caccn.ca and join us.